if you feel like standing, you can also, when there's nobody here, you can chair from here.
You have a lot of power.
It's up to you. I don't know.
Déjà, on en a parlé pendant 2 heures.
Ouais, c'est ça.
Ça, on peut répéter la conversation.
Tim, what's the name of this session?
Advocacy, measuring advocacy. Oh, stairs up on the outside the front door. Stairs. I think we can start, Jerome.
Okay. So, can you hear me?
Then the mic's not on.
Yeah. Okay. So, welcome to this afternoon session. This is about measuring advocacy. So, what we'll try and examine during the next 2 hours, we have exactly till 3 o'clock. Then we have some panelists that have to rush out. We'll be looking at really what importance do OCs put, does MSF put in critically examining our advocacy, and really how can we or should we go about this? So to be able to animate this session, we're very lucky to have first of all 3 guests that will present and I think 1 film as well, and look at how 3 of the presentations will look at how we can actually measure advocacy and what the best practice is. So we have Khurshida, who's actually has a very wide experience in terms of consultancy, evaluations, organizational development. But what's very interesting in her approach, and it's very important for MSF, is that she also touches on organizational psychology, which we need a lot of. So especially to do advocacy, I think. So that will probably help us to move the debate along. And a lot of experience also working with ICRC, MSF, and some of the UN agencies. So welcome, and we look forward to having you show us how it can be done in our own programs. I think the main focus will be on South Africa for your presentation, along with Andrew Mackenzie, who's a public health practitioner with a big experience in sub-Saharan Africa, who's also been looking at some of the patient clubs and adherence clubs that we have and looking at how that can be measured and the impact of some of the advocacy we've done around there. Then we have Glenn O'Neill, which actually has also a very big experience in terms of supporting NGOs in reviewing their communication and advocacy angles. And Glenn, in particular, undertook a full review of MSF advocacy and our approach to this over 2015 and 2016. Glenn's also got a communication background with the ICRC and some other organizations. So I think that will allow us to kind of frame the debate and discussion. And then on the panel, we have the pleasure of having Monica, who heads the reflection unit in Barcelona. We have Beatrice, who is the coordinator of the HEART team, which does the humanitarian advocacy and representation team at the international office, but also is the coordinator for the RIOD platform, the director's operations. We have Michiel Hofman, which is part of the reflection unit team in Brussels. It keeps changing names, so you can maybe update me on that one, what it's called today. And we have Hernan, who's the director of communication in OCA. So that will allow us to actually then look at what importance each of the OCs here put on that critical reflection, how it's done, what the challenges are, but also question Beatrice in terms of how can we do it and how far we can go in measuring and evaluating our advocacy at more international or intersectional level. So with this, we'll start, I think, with a small film.
Bear with me, please.
Now, while we wait, maybe I can update a bit. The microphone comes back on. In terms of the advocacy review, where we're at since that. A few people. So Glenn finished his work. Are we good? Not quite. And the IO took a reflection on how we could, different kind of scenarios we could look at in terms of organizing common advocacy, but also raising the importance that it's not just about common advocacy, but it's also reactive advocacy, and how do OCs deal with this and interact between themselves. That's another important question. And let me know when you're ready to go. And then finally, so that reflection has occurred in the IO, giving options on how this could work, and we're actually now expecting the OCs to have that debate internally. I know some of OCs have actually launched that reflection to see what they see as a support they need, how much should be done in common, how much should be done internally to OCs, and so on. So we're expecting to bring all this back together by let's say end of spring, early summer, at the level of the XCOM and MEDOP and RIOD. So the MEDOP, the platforms are also working on this in parallel to the OCs.
Hi, I'm Gavin Steadman-Bryce, founder and director of Pamoja. You join me here today on the banks of Loch Lomond, home of Pamoja and a place I often come for inspiration. And that's what I hope to do today. I hope to inspire you to think differently about how to monitor and evaluate your advocacy and policy work. If you're wondering why I've been invited to speak, it's because of my passion to bring rigour to advocacy evaluation. I began working with Oxfam in 2010, supporting them to pilot a new approach based on a method called process tracing. 7 years later, and together with my colleague Barbara Bethany, we've developed a new method called contribution tracing. From the banks of Loch Lomond, you now join me in Dhaka in Bangladesh. I'm here delivering a 5-day workshop on contribution tracing. The idea of the workshop is to help participants from CARES programmes better capture the effects of their inclusive governance work. And for CARE, inclusive governance work includes a lot of advocacy elements.
I'm Tom Aston, a governance advisor for CARE International. CARE does local to global advocacy, and the type of strategies you have varies in accordance with that. Some of it is related to international standards, which is what our international advocacy team often works on. But perhaps the great bulk of our work really is working at local level to influence local authorities to change behaviour. Sometimes that's formal, sometimes that's informal. And depending on the context, sometimes we're able to bring that up to national level advocacy campaigns with other organisations, depending on what the issue is and where we have traction really. I think there are possibly two main reasons why we increasingly want to measure our advocacy work. One is an organisational commitment, which is what we're referring to as multiplying impact, and that is a way of extending the reach and the scope of our influence, and a key means by which we do that is through advocacy. So that's a driver. Another is really to help substantiate that we're being effective in influencing, and that's something that our advocacy teams globally typically are starting to get to grips with, because they want to see what strategies have actually been most effective, so that they don't make the same mistakes twice, or that they replicate as best they can the strategies that are most effective.
It's not for me to say whether MSF should be doing advocacy work or not. I'm going to leave that debate up to you. But I do believe that good advocacy interventions can be incredibly effective at empowering people and increasing accountability between citizens and government and delivering sustainable change. The fog is slowly starting to clear here at Loch Lomond. I think actually the fog gives us a good metaphor for an advocacy or a policy intervention that doesn't actually have any good M&E in place. You find yourself wandering around asking yourself, is this the path that I intended to take, or is the path actually over there? Is this the direction that I'm supposed to be going in? If you're struggling for ideas on how to plan, monitor and evaluate your advocacy work, don't worry. There's actually a great range of freely available tools that can help you plan, monitor and evaluate any type of advocacy campaign or programme. I will post example resources on our Facebook page. The address is being shown on screen now. Just simply like the link on screen and you should be able to get access from them from there. To those people in the audience who might be thinking, it's not possible or it's too difficult to evaluate advocacy work, I'm here to tell you that it's not. As I've already said, there are a range of freely available tools on the internet that can help you plan, monitor and evaluate. And with methods such as contribution tracing, I'm showing that it is possible to bring rigour and credibility to advocacy evaluation.
I'm not sure if it's the difficulty necessarily, but I think that a lot of people see advocacy just as part of the process rather than a deliberate exercise or a byproduct of a lot of what we're doing. So it hasn't been a particular focus. It's often not very clearly defined in someone's log frame, so nobody's fully accountable for it. But very often we've achieved something by using our leverage to influence somebody to change a protocol, a policy, a budget or whatever it may be. And I think it's really important for us to see how and why that's happened.
If I was there right now at the conference in Geneva, I know that I would be telling you that advocacy evaluation isn't only important, it's possible. I know that some people still doubt that advocacy evaluation is something that isn't possible to do. And I guess probably maybe 8-9 years ago I would have believed that, because there were very few methods available in which you could rigorously assess advocacy and policy work. But that simply isn't true now. There really are a range of great methods and tools on the table, including of course contribution tracing. So if you thought it was impossible, I'm here to tell you that that simply isn't true. It is possible. I'm showing that it's possible not only in the work that I'm doing with organisations like Oxfam and here in Bangladesh with CARE UK International, but I have obviously used this with MSF too. The Shimwana evaluation is a great example of how a method like contribution tracing, which is ideally suited for advocacy evaluation, has been used to powerful effect. So for me, the question isn't about whether you can or cannot evaluate advocacy. The answer is yes, you can. The question is whether or not you want to do advocacy work and whether or not you want to learn and improve your advocacy work. If you do want to do advocacy work and you do want to do it better and find a better way, then my message to you is that you cannot afford not to be monitoring and evaluating this important work. So from Bangladesh, let me say goodbye. I wish you the very best for the rest of the conference. I hope it's an enjoyable experience and I hope to meet and hear from some of you in the future.
In Bangladesh. So what we'll do is we'll start straight away with those that are going to convince us because they've done it. And how they've done it, and what conclusions they came up to, and how our advocacy was evaluated.
Hi. So I've been asked to talk about evaluating the impact of two advocacy initiatives in South Africa. And the first one I'm going to talk about is the Stop Stockout program, and the second one is the adherence clubs in the Cape Town Metro. So the Stop Stockout program, the evaluation was actually commissioned by MSF whilst the Adherence Club was commissioned by the University of Cape Town, but MSF has been intimately involved right from the beginning over the past decade in the adherence clubs in the Cape Town Metro. So basically, both advocacy approaches are aimed at improving access to HIV care. The Stop Stockart program was started in 2013, really arose from a kind of major failure in a part of South Africa to deliver drugs from one of the depots. And it basically had a major advocacy component built into its objectives right from the very beginning, and adopted a more evidence-based confrontational adversarial approach to affecting policy and system change, largely at the National Department of Health level. As I said, that evaluation was commissioned by MSF. So they wanted to affect both the policy and the systems around delivering drugs, primarily for HIV, but also for TB and other diseases. The Adherence Club program was actually started a lot earlier in 2007 and developed a different approach. So they focused on developing a model that actually worked and then used that to advocate to change the way the health system served chronic stable HIV patients. So that was more developing a model and in an ongoing way influencing, advocating to government, working with government in a much more collaborative way to facilitate change. And essentially that was in Cape Town and in the Western Cape government. So those are two different approaches. The Stop Stockart program used a coalition approach. It worked with 5 other organizations, including advocacy, on-the-ground organizations and medical HIV kind of linked organizations in South Africa, whereas the Adherence Club worked largely within and with government and structured the way that the model was adapted and adopted. If we look at the impact, and I'm going to start with the Stop Stockart program, that's the Stop Stockart program did an annual survey of stockarts in all facilities, primary healthcare facilities in the country. And if you look at the change from 2013, which is to 2013 to 2015, you can see actually the situation's got worse rather than better, number one. But if you drill down a little bit into the details, they actually, the picture's not as clear as that. Firstly, the fixed drug combination stockouts have actually decreased from 9% to 4%, and about 80 to 90% of patients are now on fixed drug combination. So you can see that would indicate for the majority of patients they actually got better. And also in the 2015 survey, at the point of time, there was the Lopinava-Ritonava crisis, stockout crisis. That was at the same time, and that accounted for about a quarter of the 36%, which would have dropped it down to 25. So you need to drill down into data to understand it, but I'll come back to that point later. So, but what it does show is still that stockouts are still a serious problem, and that 25% of stockouts, it also shows that 25% of stockouts did lead to patients getting incomplete or no medicines at all. And there were also large interprovincial differences, as you can see, and these are largely due to supply chain management or last mile issues. In terms of the Stockart program, it had an enormous impact on mindset and policy changes at national level. And this basically was largely the kind of qualitative component of the evaluation through key informant interviews, looking at documentation, looking at media, etc., and trying to work out exactly what happened over the 3 to 4 years that the project had been running. So in 2013, there was a joint National Department of Health and WHO review of the program in South Africa, and it was stated that no significant stockouts of tracer drugs were reported during the last 12 months. And then at the same time, a little bit later, in the first annual stockout survey showed significant levels of stockout in the country. The National Department of Health, from the minister down, has shifted, the whole mindset has shifted from initial denial to partial acceptance to being a key priority. And this is documented in the media, the plans, the speeches, etc., that the minister, etc., has made. And it's also then come out in various policies and plans, which I'll show you now. So I think what's important in this is in actually how the impact occurred was the use of the evidence base through the annual survey. That was actually one of the key reasons leading up to these significant changes. And this is quite a complicated slide, but it's just basically showing that the change in government on that line, on the above the line, where they were kind of basically in denial to acceptance to basically becoming a major part of the minister's approach, etc., and speaking, and the timing of the different surveys and where the SSP challenged the status quo. So that just shows you by linking reports from the media, etc., to the surveys, that the impact that the surveys had in changing the mindset. In terms of the implementation outcomes or the system changes, there have been a number of significant changes that were either initiated or fast-tracked as a result of the Stop Stock Out program. Firstly, the government had no idea of actually what was happening on the ground, so they implemented, following the first annual survey, a stock visibility, what they call a stock visibility system, and a visual analytics network, which basically captured information both from all the clinics and hospitals in the country using an app or a online system, and then linking that to production data from the pharmaceutical companies to actually get a picture of what was going on. They changed the whole distribution system by using a direct delivery. 70% of the target is 70% of the drugs will be delivered direct from a centralized point to each and every facility. Now you can argue whether that's right or wrong, but the point is they changed the system in response to the evidence. And they developed a central chronic medicine dispensing and distribution program, which they fast-tracked. It had been started to deliver to chronic patients directly. So all these new systems actually came as a result of the impact of the Stop Stock Out program. And what has not really happened, and that's the point I'm going to make at the end, is that there's still the significant problems lying at the lower levels and with last mile delivery. So even though some of these systems have changed and the mindset has changed at the national department level, it hasn't actually changed. It's changed some, but not all, at what happens down at the bottom. The adherence club model, which is much longer and a much more model, integrated, collaborative approach, there was a twin evaluation, a quantitative evaluation, and a qualitative evaluation. So the quantitative component, firstly, by the end of March 2016, the number's gone up. About 32% of the 142,000 patients on ART in the Cape Metro were in an adherence club. So from 2007, 2016, that number's actually gone up to over 50,000 now. But there was still quite a variety in different facilities, so that ranged from 10 to 60%. Then the quantitative study did a sample of just over 3,000 patients and looked at retention in care, loss to follow-up, and transfer out, and basically showed that significant 84% were retained in care and 11% had transferred out. So close to 95% actually were still in care, and only 5% had been lost to follow-up 24 months after the enrollment. And similarly, the viral load suppression was similarly well over 80% in the study. So, and the qualitative looked at different aspects, and I'm not going to go into this in great detail, but basically the whole model was a long, over a decade, developing a differentiated care model with clinic and adherence clubs, other methods around quick pickup of drugs and specialized adherence clubs. There were a number of innovations that covered both from new distribution systems, similar to some of the stuff that the stock-up program, direct delivery, pre-packaging, etc., and a whole lot of new information systems that the Western Cape government developed. It led to significant decongestion in the clinics, and there was significant task shifting to community health workers in terms of managing the adherence clubs. And also some of what we were talking about earlier, there's been significant spread into other chronic non-communicable diseases with comorbidity clubs, and also some of these innovations have spread into treatment of hypertensives and diabetics as well. So basically, in conclusion, the stock-out program has showed that there has been improvement in the quantitative, particularly around the fixed drug combination, which I said covered most of the patients. But still, stockouts are a problem. Showed that there was a significant, the impact at national department level had led to changes in mindset, policy plans, and new initiatives, but limited impact at the local level. And that we picked up. We spent some time looking, observing, and interviewing, and looking at the data from the local level. And basically, there have been some approaches at local level around community mobilization, etc., but there hasn't been significant focus at that level, and there's still huge problems around quantification and budgeting and so on at that level, leading to problems. And in conclusion, with the adherence club model, the quantitative aspects results showed significant increase in numbers in ACs. In the adherence clubs, they showed equivalent in terms of adherence and in terms of retention and care and viral load suppression. And basically, the advocacy impact at the metro level through developing models, piloting, being involved in a steering committee, mentoring, training innovations had led to the introduction and implementation and takeover by the Western Cape government. So that's really, I think, probably... Okay, so just in summary, two different models, more an evidence-based activist approach with the SSP and more a model or piloting approach with the adherence club model. Both have been effective, but it's clear that the Stop-Stock-Up program needs to incorporate more of a kind of piloting model approach to address the last mile challenge. And the adherence club needs to actually adopt both approaches to address challenges with scale-up within facilities. Thank you.
Thank you very much.
Yeah. So any, before we go to the debate, clarification questions for Andrew? Yeah, we'll just go to... What we'll do is, anyway, the presenters can also take part in the debate, and we can get more specific questions to them about their methodologies and so on if we have them.
There's nothing online. Okay. Yeah.
No. I change. Okay, I need help. How do I change slides? Okay. Should I go? Okay. Hello again. So I will be. I was evaluating project in Khayelitsha in 2013, and for this presentation, I prepared. And my role was to actually evaluate impact of advocacy in South Africa and the impact on national and international policies. when I arrived in South Africa in 2013, MSF already had a very strong reputation as a trustworthy and reliable partner. And this perception is very different from situation when MSF started its work in South Africa in 2000, near 2000, which was absolutely on a different side of the continuum. Trustworthiness and reliability actually are very important factors for MSF ability to conduct its advocacy work very efficiently, specifically in the context when it is difficult to reach desired impact. Also, MSF was perceived as a catalyst for change and for its capacity to provide cost-efficient and scalable projects. Oops. In my presentation, I will not go into details, but I will deconstruct processes of advocacy work in South Africa that enable them to have impact. I basically will say what they have done, what type of impact advocacy managed to achieve, and how. So first one is, it's a very linear approach, which is quite rare in terms of evaluating impact. MSF in Khayelitsha was perceiving its operational research as part of advocacy. And since the very beginning, it had two specific objectives. One, to show the possibility and effectiveness of new innovative models of care, and second, to improve patient care in resource-poor settings. And in this case, MSF in South Africa did a lot in terms of dissemination outcomes of its research and publishing it in peer-reviewed journals. So World Health Organization periodically review best practices, and MSF experience and publications in Khayelitsha were included into best practices in some recommendations on HIV and TB of WHO. The way how I established impact is by looking at citations and guidelines, looking into specific references for publications done by MSF in Khayelitsha. There were other publications that were based on data received from Khayelitsha, but published by other actors, for example, by University of Cape Town. That wasn't taken into consideration, so that's a very direct impact of research onto international policies. And then once international guidelines are adopted, they are basically standards for national policies to adjust their national standard plans, national policies. And that is kind of a triangle of how MSF research was reflected in national policies. Another way of direct impact of advocacy on national policies is by implementing new innovative or prototyping new ways of care or new models of care. I deconstructed some of its innovation projects that has been done in Khayelitsha, and I came up with a 5-stage design process. First 3 steps, basically time, idea, test, and cycle. These are steps for prototyping and ideation of new prototype or new ideas. So it's a cycle of repetitive think, test, analyze steps. Once the idea or a prototype is ready and it's proven that it is viable, easy to use, and cost-effective, then MSF used to document its processes and propose for further scale-up. And almost all innovations in Khayelitsha went through this process. And then once they proved to be efficient at the level of Cape Town as a city, then it was accepted by province and then reflected into national strategy plans. It's worth to mention that MSF approach was of very high tolerance to failure. There is no data on how many times MSF in South Africa failed, but it was absolutely clear that a lot of projects were abandoned before they were concluded, and only a few ideas were mature enough to become to be implemented further at the country level. Then next slide is of more nonlinear approach. Nonlinear approach is basically when you cannot attribute impact directly to MSF because there were too many other actors or factors contributing to that particular impact. However, in case of MSF in Kailicha, it was possible to trace back idea to MSF, deconstruct the process, and compare timelines of how the process began and compare it to outcomes. So it's kind of complicated scheme, and it requires a lot of data for input, but it still was possible to do in South Africa. Here I just deconstructed 4 specific characteristics of how MSF was able to engage community and achieve a very high level of impact at national level. So first, MSF analyzed specific lifestyles and attitudes, behaviors of its target groups. So examples are male clinics or adherence clubs. And then it took a systemic approach in terms of creating support for its patients. It's included, for example, in adherent clubs. Sorry, I'll take some water. In adherent clubs, it involved peer support by example of Alcoholics Anonymous, family support to keep up with the treatment, and support of different health actors. So there were counselors, there were facilities provided for adherence clubs, etc. And inherent characteristics of community engagement processes were monitoring and evaluation included into design of its project. And finally, engagement, the feedback loop from patients was also part of the design. So this is how MSF was able very quickly to get feedback and then to adjust its processes and its projects to the reality and to the needs. Next is mobilization. So mobilization, one of the classic, let's say classical activities of MSF. In South Africa, it took on maybe new, more advanced form. So in MSF South Africa, it was very quickly realized that they will not be able to have impact that they wanted to have and at the scale they wanted to have. So instead of focusing on service provision model, they went into a highly collaborative partnership for impact. And they involved people from civil society, health departments, patients, communities, and researchers into various activities of advocacy. There were 4 shared characteristics for collective impact that MSF in South Africa wanted to have or had ambition to have. First, all actors eventually came up with shared common idea or agenda. They were working towards the same goal, but they were able to synchronize their agenda and contribute its activities to support each other. Because they have already shared understanding or definition of their success, they were able also to develop a criteria for measurement of their success. Communication was clear at all levels, and that's trust and reliability and credibility of organization was an important factor in this case. So the way how I traced back collective impact and systemic change in South Africa is by creating several timelines for each project activity and other actors, measuring a little bit or comparing level of efforts and compare it with outcome. For example, MSF created community of practice in terms of research in Kailicha and involved not only University of Cape Town, but also other researchers and practitioners to use data received from Kailicha for advocacy and promote certain models of care. and with other actors like Radio of Cape Town, or there was also circus with social agenda that they involved in order to promote and destigmatize attitude to HIV. With departments of healthcare, departments of health at the city and the provincial level, MSF worked a lot in terms of sharing capacities and then certain resources. So here I would like to share what else can be done, and that is my personal input. I think that advocacy in MSF can be adjusted to each context and can have definition for context-specific realities. It's for sure an interdisciplinary approach. You need not only medical expertise that you are very good in, but also ability to create and maintain networks of different actors. Its ability to mobilize a collective effort over a long period of time. And then in South Africa, it was very clear that MSF there for a very long time, they had a very specific purpose and knowledge that they will be there for several years, in contrast to certain emergencies where MSF doesn't know for how long it will stay. Then monitoring needs to be separated from evaluation, and organization needs to collect data about its advocacy effort consistently. Evaluation doesn't have to be end of project or midterm review, but there are some forms of evaluation when you can even evaluate evaluability of the project before you begin and establish measurements of success, or use developmental evaluation that has very quick and short feedback loops in order to adjust your activities in time. And document. This is what MSF doesn't really have as a strong asset. Thank you.
So any questions or clarification? Tim, you? Here, we got... start over the back, and then we'll move to you, Tim.
Yeah, no, it was just your remark about the tolerance to failure. Is that failure in advocacy, or the failure in getting the methods right to be able to do advocacy, or what was exactly what you were referring to?
A lot of new ideas were never tested before. So there was a rather large marge de manœuvre in terms of how much they can do and how many efforts they can put into it. Authorities and stakeholders from government side also said that one of the added value of MSF that it has resources, expertise, and capacity to actually innovate and propose new models of care that can be scaled up later on, because governments and national levels, they just don't have time or resources or expertise to do that. And failure, exactly, because we don't know how many times they failed, just based on the feedback, I know that it happened a lot of time, and there were a lot of projects that were not finished and were not replicated or scaled up later on. So we do have representatives from South Africa if they would like to add into this, but sometimes I've seen in MSF that there is no patience to fail or to get to results, and that may be detrimental to advocacy.
But it's a strength. It's a positive thing.
Oh, yes.
Yeah.
Because MSF has resources to do so. Okay. Sorry.
Yeah.
So, Tim, and then we have the one person in the back, so go ahead.
Just a quick one. I mean, your last slide, I think you laid it out quite nicely, but if you could pick one of the areas to focus in on as a prerequisite for evaluating or measuring advocacy, which one would it be? Is it the documentation, or yes? Or which one? I mean, that's a question.
Mm-hmm. Let me see.
Your slide's gone, but...
Yes. difficult because it's all come in a bundle. You need to have reliable data. You need to evaluate. But maybe what MSF is lacking in terms of advocacy specifically is to develop its own theory of change or theory how success will look like at the end, and then walk back and establish measurements for how they're going to evaluate its own project. Because right now it's happening, not right now, but in MSF South Africa, it happened a little bit more intuitively by trial and error. Well, now as you have experience, you can do it better by replicating certain experiences.
Thank you. So I think it's a clarification question actually for the first speaker inspired by your presentation, relates to the work with communities and the local level. Because I think from the presentation from Kralica, you did mention like MSF has built long-term collaboration with local communities, patient group, support different model of care. But then at the same time, we heard from the first presentation, one of the weaknesses from the stock out advocacy outcome was community mobilization was very limited in tracking. So I wonder whether they have some link in between. So what do we mean by community mobilization at local level on the stock out issue was limited at the end, while we do have long-term working relationship with the community in general in South Africa? Thank you.
So I'll try to answer, or you want to go?
Thanks. Is it on? That's okay. Yeah. No, I think in the Stop Stockout program, the big issue there was the coverage or the footprint was very small in relation to the whole country, obviously, but so it hadn't really been thought through about how to actually get a significant footprint on the ground to feedback stockout problems across the country. So where they had been active, it was actually quite good, but the coverage was really tiny. So the actual approach wasn't actually thought through in terms of how to do significant community mobilization across a wide area, which is what they set out to do.
Okay. Any other questions? I think we'll move on to the last presentation, get the debate going with the panelists after that.
So thanks for having me today. My name's Glenn O'Neill, and as Jerome introduced me, I was involved last year in a sort of global review of advocacy within MSF, which was cross-sectional. So a lot of what I say today is drawn from that review, but also from my own experience as an evaluation consultant, working for many organizations, NGOs, agencies in the humanitarian sector mainly. So basically, the first point I wanted to talk about was, well, what did we find, for example, was the current setup of evaluation advocacy in MSF. And when I say MSF, I talk about all sections, international office, field, partner sections, etc. Basically, here's just some quotes from the report, which if you're interested, it's available, summary out on the table, where we had lunch. So basically, what we found was overall there was a sort of an absence of monitoring and evaluation for advocacy evaluation within MSF. We saw today some good examples from the last two colleagues who presented, but in general, basically, there's not much really that has been going on. Of course, it's improving. Perhaps also the way advocacy is done, the second point, initiatives are constantly launched, changed, adapted, but basically there's not much sort of review or reflection as to, okay, what did we really achieve? And what does this mean for the next time we do this? And also, as pointed out also by my other colleagues or hinted at, is there's basically very limited sort of guidelines or best practices available, opportunities to discuss amongst colleagues who are interested or working in advocacy. And if such materials existed, it was more so OC specific, so therefore their use was limited and not necessarily applicable across the whole of MSF. And as a last point, what we also advocated was, which is in one of our recommendations, was, we would encourage, of course, the adoption of more monitoring and evaluation, and basically shared minimum standards tools for those working or interested in advocacy. Because as we heard, there's many programs that actually, projects that MSF is running that has an advocacy element. You have also some projects and programs where you could say, well, that's really an advocacy project or program. But you have many things also where advocacy is a key part of the project. So basically, another point that I wanted to touch on was basically, well, you know, what are sort of like the barriers or enablers for advocacy evaluation within MSF? So on the right here, you can see a list of sort of like factors that apply to all organizations. These haven't been sort of invented by myself. These are drawn from academia and literature that have found these sort of barriers and enablers time and time again. And actually, I've adapted them to advocacy evaluation, but in most cases, these could apply to evaluation in general. So you could have, like, for example, advocacy evaluation community. You could say, well, the health evaluation community or the water and sanitation evaluation community, for example. Now, how does sort of like MSF today situates itself? How do I interpret it on the basis of these different factors? And I'll explain the factors as I explain how I see MSF responding to them. Basically, for example, context. The context that you work in, of course, influences your ability to evaluate. Now, many of the contexts that MSF are working in are challenging, but evaluation is still possible. So it's not contexts. You do have contexts where it's very difficult. For example, you know, Yemen on the ground in the heat of the battle. Of course, it's difficult to evaluate. But then again, in other countries, other areas, it is possible to evaluate. And there are organizations doing, for example, evaluation of advocacy in places like the Congo, for example, or in Syria. The next one, the advocacy evaluation community. The evaluation community, those outside of MSF that are interested in working in advocacy evaluation, is quite extensive. There's been a lot of work done, as also Gavin explained in the video. I would say this can be an enabler and of help to MSF, and it's used very little within MSF. Within MSF, there's very little knowledge of what exists out there, you know, beyond MSF in terms of tools and guidelines that you could adapt and use. Funding, I would say, you know, funding, of course, can be a big barrier to evaluation in any area. For MSF, I say it's less of a problem. I believe that MSF can find the budgets and has the ability, you know, to use them for evaluation. So compared to other organizations, I would say that MSF is better placed in that regard. I think in terms of the people within MSF, of course, they can be both a facilitator or an obstacle to evaluation. There's not so much knowledge about advocacy evaluation in MSF, but people are very interested. When you go and you talk to the people on the field and the partner sections that are doing advocacy and or communications, they are interested in evaluation and really willing and eager to be involved. Evaluation policies and practices, these can also be, of course, a facilitator to evaluation. If you have good, strong policies, they can be. If you have weak, less so. Perhaps in MSF, it's really a growing area. As for now, there's little guidance for people who are interested in this and little possibility to learn about what others have done. I mean, as MSF builds up its number of evaluations it's doing related to advocacy, of course, we'll have more opportunities to learn and for people to see, okay, that's how they did it in that situation. What can I use in my situation? The next point, advocacy ambitions. Of course, your ambitions, what are your objectives and goals of advocacy, influences your ability to evaluate it. So basically, something rather specific is easier to evaluate. So some of the programs we saw, for example, the stockouts, is we can see a specific program project where we can relatively easily follow the steps. MSF has a mixture. I mean, it has very vague things, advocacy goals and aims, which of course will be difficult to evaluate, and more specific. So of course that influences. And perhaps the last point is one of the biggest influences on advocacy evaluation. It can be both a barrier and an enabler. These three I put are more sort of like barriers to do more evaluation in advocacy. The first one is the urgency culture that I found in MSF, that MSF works constantly in a constant urgency. It's an emergency-based organization. So this doesn't necessarily facilitate evaluation in many cases because people move on to the next thing very quickly. Some cases that is true. In other cases, what I saw in MSF, this was more of an excuse, you know, not to do more monitoring and evaluation. That's also, as my colleague said, you know, the lack of documentation in MSF is rather striking, I would say, compared to other organizations. Other organizations I've seen, they go too much into documentation, they have too much. You don't want to go in that way, but you've got to find something slightly in between. The second point, disbelief in advocacy, is that here today I believe we all believe in advocacy, but talking with people in MSF, there's a lot of people who don't believe advocacy works. There's a lot of people that really believe the only way to bring about change is through direct medical treatment, delivery and care. Fair enough, that's really the main purpose, the main role of MSF, but we also have to accept that advocacy can work and does work and can be more appropriate in certain situations. And many organizations have discovered that, and many people in MSF are discovering that. While not, of course, no one wants to turn MSF into one of those terrible Anglo-Saxon advocacy-based organizations that kept quoted back to me as an Anglo-Saxon all the time by MSF people. So, of course, no one wants to turn MSF into that. But advocacy can work in certain situations, as the examples we saw. Lastly, expectation in terms of there's no real expectation of MSF staff working in advocacy to monitor and evaluate. There's no expectation of their bosses that you're going to evaluate. In many other organizations, this is very strong, that you must evaluate, you must try and pull out the learnings from this. Some of this, admittedly, is donor-driven by government donors that are funding many of the humanitarian organizations. That's not an issue in MSF. MSF, fortunately, doesn't have that pressure, but it shouldn't also be an excuse not to think that evaluation can be useful and serve a purpose. So, lastly, I just wanted to say, well, what are the opportunities for advocacy evaluation that I think? I think certainly, MSF can learn from other organizations. I think MSF, what I saw in evaluation, does not like to learn from other organizations or doesn't want to see that it can learn from other organizations. And I think it can, as we saw in the video and from my colleagues, the methodologies they use. There is a lot out there in advocacy evaluation. I think tools, MSF needs simple, common advocacy planning tools across the sections, across the operations, monitoring, evaluation and learning tools. These don't have to be complicated. There's a lot of good action-based sort of tools that can be used. For example, quick, rapid reviews after advocacy actions. I think MSF needs to carry out simply more advocacy evaluation. So there's more experience and more basically cases that people can look at. And I think, there needs to be an expectation within MSF that, monitoring and evaluation and learning is important and is needed. It doesn't have to be compulsory, but if it's somehow better ingrained, that would help. And finally, I think, MSF staff that are working in advocacy or interested in advocacy, they need more opportunities to exchange experiences and share best practices, because that will really encourage a better sort of planning and consequently, monitoring, evaluation, and ultimately learning from what's being done. So thank you very much.
Okay, thank you, Glenn. So unless you've got questions or clarification, since time is running out, there's a burning clarification question that we can ask, otherwise we'll go straight to the panelists. And I think the question that really comes to the panelists, and I think maybe we can start with the OCs on this one, is first of all, what expectation do you think there is inside your OC to evaluate, and your advocacy approaches, and how are you doing this, and how are you approaching the measuring of some of the objectives that you set yourselves, if you set yourselves objective? That might also be a question. But also, once we've done these evaluations, I'm curious to know what use do we make of them inside your own OCs, and maybe critically reflect on this. Now, going to you, Beatrice, afterwards, I think what would be interesting from this discussion, we heard Khurshida say that in South Africa she had a highly collaborative partnership approach. Is there any chance that we could have this kind of highly collaborative partnership approach between the OCs for some of the advocacies? Are we able to do so? At what level? And when? And basically, can we develop a common agenda? If so, at what level? Can we synchronize those agendas or not at the intersectional level? So maybe we'll start with you, Michiel, since you're at the end. A bit of how are we evaluating advocacy, evaluating generally, and what's your critical reflection on how OCB is doing so?
Right. I didn't know that was a reason to start with me because I'm at the end. We're called now the analysis department. That was your question. That we're changing names all the time.
Yeah. So what is your name?
Analysis department.
Analysis department. Okay, fine. AD.
Exactly, yeah. But I'm sure that will change again in the next 1 or 2 years, so don't get too hung up on that one. I mean, I don't think, because I get the impression from these discussions that people think there's a particular problem with MSF's ability to specifically evaluate advocacy. Whereas I just think it's not specific to advocacy. I don't see a reason why you couldn't evaluate advocacy, just like why you couldn't evaluate your operations or your medical objectives, as long as you have a clear objective to evaluate, which is not always the case. And I think MSF struggles generally with that, and not only with advocacy. To actually formulate a clear objective. And let's face it, in our medical operations, half the documents still list as the objective of the project to improve access to healthcare, which is so vague that it's very hard to measure, and we end up almost never actually measuring that anyway. So it's not specific to advocacy. So so I recognize a lot in what Glenn is saying. Yeah, we don't have donor pressure to do it. There's an urgency culture. So whether it's advocacy, operations, medical outcomes, in general, I think MSF has a problem to spend a lot of time and energy in monitoring and evaluation. And OCB is not different in that, especially since being clear in formulating clear objectives is probably not one of the strong points in Brussels. They're not big into logical frameworks and bullet points and all of these things. So lacking clear stated objectives makes it even less likely that you're going to evaluate that afterwards. Plus, I think there's a tendency, because we're not forced to evaluate. MSF's evaluations are all self-evaluations. The operations usually launch their own reasons to evaluate something, so they tend to favor issues, projects, situations that we already know had a favorable outcome. So we end up with a lot of evaluations that congratulate ourselves, which is very nice and can be very useful, and there can be some tweaks in terms of the lessons learned, but it's not going to really majorly change the way we work. What probably is more than with operations, because I exaggerate a bit, is to say all operations are defined as improving access to healthcare. Sometimes there's clear operational goals like reducing the incidence of HIV or increasing the number of patients on TB treatment. And then, of course, if you have a clear objective like that, then the likelihood that you're going to actually measure if you actually increase the number of TB patients in that particular location is quite high. And that, I think, is the big problem with advocacy, that we are very good in defining our témoignage, so the witnessing, which is not the same as advocacy. That just means you cry out about a situation, you tell the world what you think is bad. The advocacy comes when you actually then are also going to say what you think should be in its place. And that is where we struggle to internally in MSF, within the OCs, between the OCs, within departments, within desks, within missions, between each other, within our own heads, to actually come to an agreement of what do we want to advocate for. We know what we want to witness against, but to actually define what we want to advocate for is extremely challenging. And I think that is when, even if you want to, you put resources in and methodologies and partnerships and tools and everything else, and willingness to evaluate it, if you don't have a stated objective, what are you going to evaluate? And that is probably more of a problem with advocacy than with the other activities that MSF does. And like I already said, within OCB is not an exception to that, especially in a place where stating clear objectives is considered a bit too bureaucratic anyway to consider as a daily activity. That's it.
Okay, thank you, Michiela. So, with Monica.
Okay, I think that I second a lot of everything that Michiel has said. I think it is. I mean, the key to it, to deciding whether you've done well or not in advocacy, is to knowing, you know, what is it that you expect to get from it. I think that when we speak of advocacy in MSF, we are putting in the same basket a whole range of things, and I think that we need to be clear that each one of those categories has different processes, different obstacles, different enablers, and we cannot and will not find a formula that works for all of them. So we have, you know, the presentations today were about programs that either exclusively about enacting change or that have an important change component. So those are set out objectives, and it's relatively easy, or should be relatively easy, to look back and look at whether it's been accomplished or not. But there is a lot of what goes on. I mean, I think that advocacy is a core component of line management, of what the heads of mission do, what the fieldcos do, what the desks do, and a lot of that is not registered or labeled as advocacy, is not measured as such. So a lot of that can only, I think, be evaluated and looked at if we look at the whole of the operational objective. So what are we trying to achieve here operationally, and then we will look at from an operational angle and eyes, I'm sure that we will find advocacy initiatives or things that have been done from that angle. Then I think that another big category is the advocacy / positioning, and I mean positioning because positioning sometimes stops at just saying what we don't like, right? Sometimes it goes further into advocacy related to crisis, and where the sense of urgency is much stronger, but also the dynamics in the organization are very different, both intra-OC but inter-OC. And then there is what is happening quite a lot lately, the higher level political messages on global things and that are being done at a more institutional level of the organization, and that again responds to a different set of dynamics and would require a completely different way of measuring it if it has some impact. I think that I just like to note that the advocacy review, I think, focuses on more the sort of explicit advocacy objectives, so I think it misses a lot of the other things. So a lot of the dynamics that are, I think, that actually relate to the bulk of our advocacy work are misrepresented in a way. So are we wanting to do evaluation of advocacy in OGBA? I think that we don't necessarily want to separate it as something that's outside of operations. We see it, as I said before, as an intrinsic part of the operational work. And as such, I think rather than, do we want to do a lot of it? I'd say maybe not so much in terms of formal evaluations. I think that we are interested in clearly defining advocacy objectives if there are some. I mean, in the last year, I've been involved in a number where we are, making an effort to define what is it that we want to say to whom, for what, and what do we try to achieve from it. That is kind of easy to review, but that we kind of do very much real time, because it kind of, the operations are very linked to that. So I think that it's what we've been trying to do in OGBA a lot is to have these kind of real time critical reviews, sometimes with different levels of formality, but definitely something that we're trying to invest in, involving the different layers of operations, from the field coach to the head of mission, the desk, director of operations, and people, myself or people from my team. So clearly there is a desire to do more and to have that feedback immediately and to adjust, our ambitions. What else? I think that for Eva, there is room to do more and better in terms of evaluation generally in operations, and I think that rather than try to adopt an advocacy frame into what we do in our operations, I think that we need to include typical advocacy questions in our normal operational evaluations. That is, we know that in most of in many programs, we might have advocacy related to access, to increase visibility, to bringing in new actors. So rather than separating those out as separate evaluations, I would say let's make sure that we ask those questions when we do operational evaluations and look for the data, not as a separate thing that has to be registered separately, but as something that you should find in a well-written SITREP and like the normal documentation that we should, and I know we don't often have. Yeah.
Okay. Yeah. Thank you. We'll move to Hernan. You don't mind going last? Okay.
Well, hello, everyone. I'm going to make a couple of really scattered points, trying to not to repeat what other people have said. But in looking at the presentations, I'm not really convinced about this seemingly newly discovered field of advocacy evaluation, right? We're talking about evaluation, period, and it's a deployment of methods and a structured methodology to ask questions about the design, the implementation, or the impact of a program, right? So you gather information, quantitative or qualitative, to just let's see how this worked. In that sense, I don't see advocacy as as a separate field, or as you evaluate the program, and advocacy is part of it. So I would not be very supportive of the notion of let's create a field there that is advocacy evaluation that somehow is different. I don't see any difference. I think perhaps the only difference that you have with advocacy is that we get this confusion about impact. How can you measure the impact if there are so many? I mean, look at what we've done with refugees in the Mediterranean, and the situation seems to be worse. But it's not just us, right? There's from ISIS to governments but we get confused into like trying to focus on that kind of evaluation, and perhaps we forget that we can evaluate other things. You can evaluate the design of your advocacy. Did you actually define any objectives? Did you have any plan? You can just look at that. Did you think about it? I think that if you look at some of our programs, you will say that yes, we do. We do think we have a plan, and some other programs we don't. You can also try to evaluate the implementation, right? I mean, did I actually go through the motions of doing the things, and was I reactive? Did I adapt or not? So I think that there is perhaps not, certainly room to look at how we do things and to do things better, certainly. And myself, I'm not here to claim that we do things great. I want to link that to the notion of organizational learning, because for me, I mean, you ask all these questions, why the hell do you evaluate? I mean, because you want to learn something, right? You're going to adapt things, or I'm going to do it differently next time, or whatever. I think the real question is that, I mean, some of the speakers said, okay, well, the MSF doesn't want to learn, it's not that keen to learn. I think there is a culture of that. I see that. But I also see there's a massive bottleneck in terms of our ability to act upon recommendations from evaluations. If you see how we run our programs in the field, someone said this morning, we have an average mission duration of an expert of 5.3 months. A massive turnover, loss of information along the way, massive changes in context. So I think that there are difficulties in, I see a lot of evaluation reports that end up in a drawer, and not just because of the culture is hostile to it, but also because it's when you are running a mission in the field, you normally, head above water. So I know that sounds like an excuse, but it's not a coincidence that a program in Cape Town can do this better than a program in Syria today, right? I mean, it's a fact. I mean, in some places you can, some places more difficult. So Monica said about there are other ways of also evaluating. I think that we have to look a bit about how does MSF learn. I'm not sure that the way we do evaluations, or the traditional way of like go get. I think there are other ways that we can quickly evaluate or sit teams around, try to learn, try to adapt, document. That perhaps there are a range of ways of learning. Because for me, it's not about evaluating, it's about learning. I mean, donors are interested in evaluating to see if they give money to things. But for me, it's more about how do we learn. And in terms of what, you say, how do we do it in OCA? I wouldn't do, specific evals on advocacy. I would just evaluate advocacy with the rest. I think, we put a lot of effort. I mean, in my department, it's probably the only OCs, and I'm not saying this because there's more success, but there is we have dedicated, humanitarian affairs advocacy people that work with the comms people within my team, and they are attached to missions within desks. So there's a lot of effort in missions to say, what the hell do we want in advocacy? What the hell do we want to leverage? Whatever. Sometimes we get it right. Sometimes we don't get it right. Sometimes we have missions that have a very clear set of ideas on how to do things, and some missions don't. And it depends on the people. It depends on our ability to influence. But that can be improved, yes. There are those, yes. Those are that Michiel was referring to. If you see what MSF intersectionally how we struggle to define objectives for the refugee or migration dossier as a single entity. We struggle, and we're going to continue to struggle, but that's not a problem of the advocacy. It's a choice. It's the design of the organization. You have 5 operational centers that have their own reading of a situation, their own operational presence, their own bias in how they see things. So that's a choice. I mean, it's a self-inflicted result of how we are, right? So I'm not going to talk anymore. Those are
That's a perfect handover, I think, to you, Beatrice. A choice, a self-inflicted reality that, unfortunately, you're having to deal with quite a lot of the time, or fortunately, let's see.
Did it work? Yeah. Well, so you have been listening to presentations since an hour and a half, so I'm going to do 5 bullet points. Okay, for bullet points, Mikil? So the first, and I would like to connect the dots also with what happened since Glenn delivered the advocacy review report. We've been kind of starting to reflect on, maybe it's artificial, but to operate a distinction between long-term advocacy priorities and, let's say, reactive advocacy, what corresponds very much to what you were saying, Monica, let's say the daily advocacy that we are facing with operations. And I would say the long-term priorities, there is a proposition that's been issued by Jérôme and others to have a specific process through the MEDOPS and Mercedes, and to indeed at least agree on a few top priorities on which we would, as a MEDOPS, but also with the whole capacity of the movement, invest on. So I think that's one thing that we can park. The rest of my remarks are going to be more on this reactive advocacy, the one that is basically, as you were saying, the bread and butter of what we discuss with the desk on a daily basis, also with the RIOD. And there indeed, well, we are doing a lot, and on the other hand, we have a number of challenges. Some of those challenges are related to some of the things that were mentioned earlier. The first challenge is, before evaluating advocacy, it's about having a set of kind of tools and fundamentals in place that you're going to use as a benchmark to actually look at your advocacy and how you have performed, etc. First, as some of you were saying, we don't have necessarily the same understanding of what is advocacy. So some people around the table or in the same call would be thinking of positioning or big comms, and some others of policy change, etc. So there's already maybe a discussion needed to just agree that we have different options on the table and what are we talking about. The second thing is, and that's not judgmental at operation, but just what it is around the table, and for instance in an interdesk, or I can imagine also with the heads of mission or with the RIOD, you can have different, especially in big contexts like Nigeria, Iraq, Yemen, you have different operational strategies and different approach to advocacies in different OCs. And it doesn't mean that one is better to the other, but you have kind of this a pull and push factor. In French, we say centripète, centrifuge, so one going in this direction, the other in this direction. And at the end of the day, you can add up for 3 months, kind of trying to finalize your briefing document and trying to finalize your approach to advocacy. And in the meantime, situation change, and in the meantime, we have the challenge of time. So I would say, and it's all, as I really like what you said, Monica, that it's ingrained in operations. So and it's moving very quickly, a long time. So I'm wondering how we can still, again, have some sort of discussion, ahead of the crisis, to agree on this kind of basic understanding of the fundamentals, the tools, how we deal with tactics, how we deal with dissemination, etc. In this part, there is a bit missing piece on evidence. At intersectional level, I think it's even more striking than at section level, because you end up in function of the dynamic in a country in between sections, or if also of the initiative of different OCs, you will have in some context a lot of documentation, and in some others 3 to 6 months to agree to send an intersectional person to do some basic data collection. So, and it doesn't mean that we want to be more, better in advocacy in one context or the other. It's just organizational or institutional kind of force of inertia, I would say. So, these building blocks, let's say basic fundamentals, I think it's a challenge to the intersectional kind of delivery of advocacy, and therefore evaluation. Another point is our relationship to time, which I think is a challenge within the OCs, but also intersectionally. Some of us in the movement, we consider advocacy as something really like short-term, and we do indeed speaking against, or some strong témoignage, or some other would be looking at more sustainable change and some multilateral diplomacy, for instance, or advocacy, like 2086, you know, the resolution on the attacks on the protection of the medical mission, for instance. So you have very different relationship to times, and therefore I think it's complicated to manage on a daily basis. Some people saying, well, what's the use, and therefore what's the performance of MSF of having been investing in a resolution of the UNSC, while on a daily basis we're continuing to being bombed. So, of course, the different levels coexist and nourish each other, but I think it makes the discussion complicated at an intersectional level. Third point is about the political nature of the intersectional discussion, and I think it's something also interesting at this table, because the evaluation that we had were very operational and very medical, you know, on some projects. And a lot of what absorbs also the advocacy and positioning discussion at movement level are super political type of advocacy on refugees, on the WHS, on attacks on hospitals, and it gets, you know, aspired to the top, to the ExCom and to the institutional and IB, and to this very kind of top level, top political level of the movement. While you have, on the other hand, the projects and the missions and the desk who may face a different reality and have different expectations. And so when it comes to evaluating all this, you have a basic kind of, let's say, coexistence of very different levels to reconcile. And the last point I would like to make is about the HEART team, which I coordinate, just as a matter of clarification, because so in the chain of advocacy, like the different sort of functions that you do or roles that you have, it starts from the documentation, we're talking of it, and first the project actually, and then the documentation, the discussion around the strategy, and tactics, target audience, dissemination, representation. Where we see our added value as a HEART team is definitely in the representation and dissemination part, but also with having some continuity on some context and some expertise amongst some of the members. It's about helping to inform some of the tactics and strategy, and being kind of helping as much as we can, the intersection or the OC concerns on a specific strategy. So it's not about content production; it's about supporting these dynamics. And the way we see the learning in this environment is evaluation, not sure, but we're trying to go more for lessons learned, experience, because it's true that in our practice at OC level, but also at movement level, we do a lot, and we learn very, very few of that. And I mean, especially for my part, which is more on the humanitarian diplomacy or representation, it's something we have very little, still knowledge and experience inside the house. So I think it's interesting to invest more into that part.
Great, thank you very much. So now let's open up to the floor. We have 20 minutes before we get to wrap up. So we'll start up here in the front, then we'll go to Brice. Go ahead. Go ahead.
So it's questions from people following us on streaming, from MSF OCA in Zimbabwe. More or less, what methods were used to establish that there is no advocacy evaluation within MSF? So it's a little bit linked to the presentations we had at the start of the session. And does this also apply to the Access campaign? Was the question from OCA in Zimbabwe. And then they had a comment as well that there is advocacy on a daily basis. For example, when a doctor advocates for protocol change at the clinic level, and then the advocacy is indeed measured as there is a measurement of the project objectives and of the activities. Okay. And then I have another question from François, medical director of OCBA. But this question was more or less answered by the panelists already, but it was a willingness from his side to have a more broad answer from MSF as a whole and from the international office. Do we really need external post-ante evaluation to know if an advocacy project or objective has reached its goals? And isn't it a problem of poor design of the advocacy initiatives, the fact that we need to have a separate evaluation? And as said, this has been a little bit answered during the discussion. And the last part of his question, shouldn't assessment and reporting on achievements and lessons learned be part of the advocacy initiatives themselves? It means that it should be built in order to avoid issue to do with follow-up later on and bias, loss of information, data, etc.
Okay, so we seem to have a few statements and a few questions. The question that's easy to actually answer, the Access campaign did go through an evaluation, and actually the job that Glenn did oversaw 2 evaluations, one which was more on the general advocacy, one which was more on the Access campaign, which is actually available. So that question, I don't think we're going to go through the Access campaign evaluation, but it's available, the evaluation and the follow-up to this evaluation that was done by the Access campaign and the XCOM. Now, on the daily basis, I think it was touched on, so I'll go straight to Brice if you have another question, and then we'll see how we allocate some of the questions.
Can you hear me? Yeah. I'm Brice, the Director of Operation for OCB. Now, I wanted to strongly react on the remark of Michiel that Operation is doing a self-congratulating evaluation, which I strongly disagree, of course. I mean, we really have other stuff to do than self-congratulate ourselves, basically. But it's an important point, I think, where in OCB, what we try to do, we don't believe, of course, there is the evaluation you need for a certain accountability process that you need somehow. I don't think it's because you have external people doing so, bring you specifically quality of evaluation. You can also have internally, I believe. And also to say what we try to do in the operation is exactly the contrary. We try to pinpoint our worst weaknesses and to do evaluation. It helps us basically to integrate those recommendations inside the project cycle, of course. It's the classical thing that everybody is saying that is doing so, but actually it's quite rare that you see that. And at the end, most of the evaluation end up in a keyboard or somewhere. Then what we try to do is really to be accountable to those recommendations, but we have the opportunity to reject or accept a recommendation, and we can explain, but we can totally reject them if we want to. Then I think it's interesting a way to include that completely in the operational cycle, basically. And of course, for advocacy, I mean, it's just, I think it's very important that we can deploy tools, basically, to do exactly the same thing here.
Okay, so I'll let Michiel react a bit later about operations really being not just self-congratulating, but pointing in their critical areas. Yes, go ahead, Taman.
Thank you. It's hard to be skeptical about, evaluating things and learning from them, but I'll try my best. 2 things worry me about the way, if you take it on the surface. One is that evaluating the impact almost tells us that if there's no impact or little impact, we can drop the whole advocacy altogether. And arguably, advocacy is part of témoignage. It's in MSF literature, and I can't see us, it's okay to not have a massive impact, exactly as well as it's okay to choose to do an operation and not necessarily save the world in every operation. And I worry about the implication that advocacy is just a tool that you could drop if you don't achieve regular high impact measured and asserted. The second thing is the way it's being described starts the evaluation from the moment advocacy starts rather than from the time choice of what advocacy to do is done. So, for example, in Andrew's presentation, you've talked about 2 already chosen ways to advocate. You didn't tell us that you've chosen to evaluate, for example, whether the activist or the other model were chosen right. Was it good for the situation? Would it have worked better if you chosen another model? And in an evaluation that assumes that the initial choice is always right, doesn't examine the initial choice to what methodology to use or whether advocacy in this mean is good, it misses an opportunity, because I think it's harder to choose what sort of advocacy to go for than to just prove the impact or whether we followed it right.
Okay, thank you, Tamam. Should we go back to, well, I'll have to take 2 more, then we'll go back to the panelists to react on some of these questions. Marcel and then Annelie.
Okay, I just wanted to echo what Brice said, but link it to something that Hernan said. So indeed, we have in operation, by the way, I'm Marcel, I'm Director of Operations of OCA. It is not about congratulating ourselves with our achievements. It's not also the butcher checking own meat, as a Dutch saying says, but it is for me very important that the same people that will be in the same situation next time learn. So we have done a lot of reviews in the form of workshop of the people actually involved in the operations. People know themselves what went well, what didn't went well, learn from each other, try to extract lessons learned so that they can be implemented next time. And therefore, you need to, in my view, do those program evaluations, including the advocacy objectives that there may be in a program. You need to learn these lessons together. And then that is the best recipe to make sure that something, if there are lessons learned, that something of that will remain in the heads of the same people that need to make the decisions next time. So I think the focus in many of these discussions is too much on evaluation as a reason in itself, but I want to link it to what Hernan said. In the end, it is about what do we do with all these evaluations and how do we implement the lessons learned.
Okay, Annelie.
Yeah, hi, I'm Annelie. I actually forgot to introduce myself before in the last session, so I can do it now. Have been working with MSF for a long time, now working in a medical university in Stockholm. And I just wanted to say, I sort of miss I think in the beginning of this session it would have been really nice to have a definition of what we mean by we don't even actually in MSF we don't talk about advocacy because we talk about advocacy, right? So that's just the start of it. And I think we are talking about a lot of different things. And I remember when I was working in the Swedish office also responsible for advocacy, and we were trying to define, so what is that for MSF? And I'm trying to get the sense of if we're talking about the same thing, Tamam, because a lot of what we were seeing as our duty to do was not so much about advocacy, trying to reach somewhere, trying to come with a final solution. It was really about some sort of targeted témoignage somewhere or targeted awareness raising, which is important. And I think it's important in missions everywhere to have the direct channels to decision makers and to make them aware of this is the situation. But I'm wondering if you're also including that, because it's very difficult to evaluate the outcome of such an awareness raising, but I think it's very much the duty of MSF. We have to do that. We have to somehow speak out and talk about what we see wherever it is and talk about the consequences of different strategies and so on. So it was more a question on what are we actually talking about and the definition around that.
Okay, so let me just, we've got two people that I'll just wait a bit because I think maybe you want to have some reactions from the panel. So we'll go to Rebecca and then we'll go to Mitt and then we'll come back to the panel, to the presenters. But already some reactions in terms of, Mikil, you made quite a bold statement that you feel generally, again, the bold statement helps. We're not very self-critical and the operations are not choosing, I guess what you meant, the things that hurt to really have a look at them and see them in detail. Can you just elaborate a bit? Because I think both Marcel and Brice disagree with you, but you've obviously got some experience and exposure to this.
Yeah, well, obviously they have a different experience on how they see their capacity to self-evaluate and how it may look from the outside. That's just what I'm saying. I remember big evaluations that were presented externally in the last year from OCB. That was the Ebola evaluation, which essentially said that a few things could have been done better, but generally MSF was wonderful. And then the other big one that was presented in this forum was the evaluation of the support program in Syria, which was also 20 slides of MSF is wonderful, and then 2 or 3 recommendations of what could be slightly tweaked. So from the outside, it looks a bit self-congratulatory. That's what I'm saying. I'm sure internally there's a lot of tough lessons learned and very robust workshops in which internally we are criticizing each other and learning lessons. I just wanted to make a few remarks that, yeah, of course we can always endlessly debate what the meaning of a word is before we even start looking at the word, but I think everybody is capable to type in advocacy in Google Dictionary and see what the actual definition is. So I find that not a very useful thing, and yes, it is different from witnessing. Witnessing we do very well. Witnessing we should keep on doing. I agree with you, Tamam. If we see that something terrible happens, just saying that it happens is a good thing in itself. It doesn't have to be combined with advocacy. That is a good thing in itself. Outrage is a valid reason to actually do witnessing. It doesn't necessarily have to be leverage or anything like that. But that leaves it, of course, and when you do decide to do advocacy, because that is an actual action, advocacy, that means you are wanting to change somebody else's behavior, and in our case, on behalf of the patients that we serve, yeah, then you need to come with your objective. So I don't agree with statements like, oh, but it's just because we have so many different operational strategies. I don't think we do. We seem to do wanting to do exactly the same thing at the same time, at the same location, all the time. You know, there's 1 year there's no boats from the Mediterranean, and we let everybody drown. The next year, suddenly, pop, 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 there's 3 boats doing exactly the same thing. So operationally, we seem to have actually quite the same strategies. But then when it comes to deciding what that means for advocacy, yeah, of course, then it starts to get difficult, because then you have to weigh not just what we think is a good strategy, because whether it's a press conference or bilateral meetings or just informal chats in a cafe with a local community leader, those are the tools. You still need to know what the objective is with that tool. So I don't think a debate about, oh, for some people it means a press conference, and for some people it means having a cup of tea with a community leader, that is just discussing what tool you're going to use. You still need to agree on an objective. And then that's where your difficulty comes in. So this stuff that is being evaluated in South Africa, that happens everywhere all the time. MSF is an emergency organization, so 90% of our advocacy is not long-term access campaign-y stuff. 90% of what we're doing is, oh, we want to open a clinic here, we have a problem because the government doesn't allow us to import this medicine, so we need to have an advocacy campaign to actually convince the decision makers that this particular psychotropic of this particular ART needs to be in their protocols. And then we launch a advocacy campaign, talking to decision makers. Sometimes we do a little bit of communications with it to nudge them a bit, and at a certain point they change their protocol, and we can start treating people with what we want. And then obviously then it stops, because you have a clear reason to do it. You do it, you're successful. And so that is all short term, and that is good. That is not a bad thing. And then there are some dossiers where indeed long term needs to be, if we decide to spend a whole bunch of MSF resources in reducing the price of medicines, for instance, as MSF decided 50 years ago, yes, then you create something like the access campaign, and then you have a sustained campaign to do that. And there are certain other dossiers you can decide to do that. But the bread and butter of MSF is linked to operations. So I agree with Monica. Normally you don't evaluate advocacy by itself. It is something that is a normal part of your operations. And if MSF comes around to actually evaluating that, then the advocacy component you also evaluate. And that's it.
We'll go to Beatrice, and then we'll go back to the audience.
Yeah, I had 1 point, but now I have 2 points. I'm coming back to the intersectional, again, discussions. Of course, you have we don't have radically different operations, but I think, and I was talking of approaches to advocacy, you have different cultures, different approaches to advocacy within sections. Take, for instance, OCP, you're always very strong in, going to negotiation, field level, strong external comms. Some other section will be looking more at will be more keen on engaging into multilateral level. Some others into bilateral engagement. And we can see that in a context, for instance, like Yemen, where nearly all the sections present have been bombed, and the approaches to the various incidents and to the types of advocacy needed for the operations has been slightly different in function of the context. And then you have MSF being very, very visible on this topic and this type of question that arise. So I think the approach is to advocacy, because we don't have the same definitions and also because we don't have the same kind of working culture in the various sections, is not converging radically, and is a parameter for intersectional discussion, in our intersectional complexity. The other point I wanted to make is, since especially Marcel, you were saying we need to go back to projects and lessons learned and really integrate, the way we look at advocacy in operation and the program level, which I agree 100%. I'm just coming back with again the intersectional dimension, and what makes it complicated sometimes at intersectional level is, again, first you have several operational plans or projects, and in addition to that, again, the political level, and so it becomes super sensitive. Sometimes sometimes it makes me think, at the difficulty we have to evaluate kidnappings, for instance, or crisis teams, crisis cells. In a way, advocacy is that sensitive as well at intersectional level. Indeed, it's a good example. It was very tricky. I think it was very difficult for OCB to also manage the advocacy part of the Ebola evaluation for obvious reasons, because it was a big part of it, and so yeah. Each time you talk of evaluation, it's a heavy process. It's anchored, it's connected to accountability and being judged, and the whole, political dimension of the movement, and it's tricky. So I wish we would manage to indeed reconcile the program level and the very lessons learned and operational dimension with this whole other intersectional kind of level.
Okay, let's go back now to Rebecca and Mitt. Then I'm going to let the panelists, the presenters, give a few comments.
Okay, thanks. Rebecca, International Board, 2 very quick points. I think most of us in this room, or at least a lot of us in this room, we grow up with an organization, with a culture of organization who was learning us treat and witness, treat and témoignage, but also treat and strive to catalyze changes, to improve the situation for the population that we assist. So whatever is the confusion around the terms of advocacy, I have difficulties to figure out why we keep coming back on difficulties on defining. I was a bit concerned with the third slide of the third presenter, that between others introduced also what he called his finding, the disbelief he found in MSF through the interviews, that quite a big part of MSF people, they don't believe in advocacy. So for me, it's something that we really to bring back and start discussing and reflecting about this, because I think that the difficulties that we have is not so much linked to the definition of how each or every one of the 5 operation centers or projects and desks they understand advocacy, but how far we are committed on this very principled idea of MSF, that we treat and we strive to catalyze changes for the population we assist. A second comment on this, strive for intersectionally building maybe advocacy agenda. I really understand the difficulties. I really understand the choice. It was said already from the previous discussion that by the end of the day, we have a choice to be different, 5 different operational centers, but still, I cannot really understand from the moment, for example, the example of last year. what we are facing today. It's the attack. I will use the example on the attack on the medical mission, the attack on the hospitals. By the end of the day, the attack on the impartiality of the humanitarian action. This is going across all of us, being OCs, being sections. So still I'm struggling to understand why it becomes so complicated. The 2 or 3 common concerns not to be developed in terms of strategy, multiple objectives, etc., etc. So I think that what by the end is our problem is much more political than technical in terms of even setting clear objectives and being able to assess. So evaluation it's an important tool, but in a certain moment, I think that the political dimension of the decisions that we make or we block needs really to come back in the discussion, because it's not only the evaluation that will take us forward. Thanks.
Okay. Meet. And I'll get to you. We'll have Meet first, and then we'll go Meet, and then you.
Yes. I had a question and on the methodology, which is linked, I think, to the specificity of MSF. Also, the review that has been done overall. So, if we speak about advocacy in wanting to change certain things, and we know that there is resistance internally and so on and so on, but then I find it strange that the review mainly has been an internal review only, and the perception of different people. We have not asked, as far as I could see, what do others think that we could do better, how we could do better, and so on. So I think it's a symptom a bit also of our self-absorption a bit. And also, I think the discussion following it on focusing so much on how do we organize ourselves, how do we set priorities, and so on. It's again about, internal, it's the internal battlefield. It's a occasion for internal battlefield again, instead of thinking more about what can we do to improve the quality of what is done in terms of advocacy, how can we be a bit less sloppy maybe and have lessons learned from what is being done. I think it's important that that part of the conversation comes out also, and that we are not only speaking about the tip of the iceberg, what the hard people are relaying, but also all these other people. The 2 presentations that were done this morning, there are many others, I think, but they never make it up to the top. And they need support also to improve the quality of what we do in terms of advocacy and having impact. So I think it's, in the discussion, we need definitely to bring in the external world, because otherwise we will turn around in a circle.
Then I have a question to you, Mit. You're part of the Reflection Center in Brussels. How often do you bring external reflection to the operations to actually challenge this? And why are you taking this to the international? And more, how is it happening in OCB? Why is it not happening in OCB? These are the questions that I also have, not just at the international level, which gets more complicated.
So, I don't say that it's not happening. I think it's happening a lot at the level of the countries levels and of the regions, but it is not it's not sexy enough to get up high enough for the discussion. That's my. And we know intersectionally there are difficulties because, like you said, some people don't believe in advocacy. It's an easy way to say I don't want to speak about it. So when just an anecdote that is that when we had a little discussion, some people think that advocacy is whispering in the ear of the mighty. While my point of view is you can at the same time piss in their boots also, but but it is important to know, and that the person who gets the wet feet knows why you're doing it, and that you know also why you're doing it. If it's only to relieve ourselves from, no, we need to know also what is the impact.
Okay, we'll have. We've only got 10 minutes left, and I do want to give everyone a chance to actually be able to say a few things. you actually have to go.
If we want to do a definition of advocacy, I like that one. Pissing in the boots of the high and mighty. I will leave with that notion. Yeah.
Okay. So then we'll have just two more, but keep it short, please, and then we go to presenters.
Yes. Hi, Carline. I work with OCA with the emergency desk. I just want to say, because I hear all this, they don't believe in advocacy, and it does make me wonder who did he talk to. Because if I see the people in this room, I don't think that's a sense I get. And I think, like we already struggle with the definition of advocacy, I think where everybody struggles, the heart in the first place, is this big international advocacy, because we struggle as a movement at times. And if I look at field, if we look at Michiel's clinic, we're actually extremely successful at field level, at project level. I had a team in Yemen who said, yeah, we didn't do very well in advocacy. I said, you managed to open the front line for injured patients of the other party, of the other conflict party. What do you mean you're not successful in negotiation and advocacy? So we have a tendency to see, well, we didn't stop the war in Yemen, so we failed. Well, I can tell you we'll probably be unsuccessful, but sticking with the mom, we shouldn't stop trying. Saying all that, one of the messages I want to put on the table here is, I think we can improve, we can be better structured, saying that OCA is a bit paper chefy already, so I think that's more applying to OCB. But what I think is often the core, I think we're not that bad, and I think if you look at Haiti emergency, the earthquake, at Haiti cholera, even at Ebola, and other conflict settings, even at Yemen, when it really matters, and we have really a message which is on the core of the organization, we're damn good at advocacy. Where do we struggle? Where does the politics come in? Actually, when we reach that level, nobody disagrees that airstrikes on hospitals are unacceptable, against humanity, etc., etc. Where do we struggle? The moment we have to decide if we think we should call for an independent an investigation. That's where the struggles start. And that is the moment you start to reach the limit of what's MSF's core. What do we, to make it basic and simplistic, as doctors have to say about our patients? The further we go away from that baseline, hey, they're killing my patients, the more we struggle. And that is actually because, and I had it with Ebola as well, Brice, I think when we shouted out, we need help here, this is a world problem, this is unacceptable, we were fantastic. Why did we struggle afterwards? Well, if you ask me, because we had nothing to say. We didn't have a solution for the Ebola outbreak. We just helped together with all the actors. We tried to figure out what was the right strategy. So when people say, well, we're not that good in advocacy in Ebola after the initial period, well, we had nothing to say. I mean, that's my personal opinion.
Last one, Barbara, and then we'll go to...
Hi, I'm Barbara from the Heart team in Geneva. I just wanted to bounce back on Mit's comment on the self-centeredness of MSF reflection and advocacy. I think one element is that is maybe missing is the reflection on the environment, because we don't do advocacy in a void. If we agree that we do advocacy for change, that means that we do need to understand whose behavior we are trying to change and what can we put ourselves in the shoes of the people we are going to change behaviors, and what are they going to be influenced by? How are we going to make them, what is going to make them tick, and what it is that is going to change their behavior. Maybe we lack this reflection on the environment and a better understanding of the other stakeholders' minds to better understand how to influence them.
So I want to go back to Khurshida. I think you wanted a comment.
I'd like to comment a little bit and maybe reconcile two requests that seem irreconcilable or controversial. On one side is how do we learn, and how do we learn from past experiences, and another request is document, document, document. I would like to offer in this regard a metaphor that might probably help MSF to reflect on that and embrace who you are. You might know that there are two types of culture. There is sedentary culture and nomad culture. Sedentary culture leave after it a lot of artifacts, buildings, manuscripts, stories, etc., books, libraries. Nomads have nothing, don't leave anything. They leave pictures on the wall. They leave stories, songs. And if metaphorically speaking, I would compare MSF ability to learn to those of nomad culture. Some anthropologists were saying that if this tribe didn't leave anything written behind themselves, that they didn't have written culture, means that they were stupid. And it's not that. It's just different ability to learn and implement and share examples. And maybe instead of trying to become someone else, you just embrace this oral culture. You don't have time to document, to write reports, draw, sing a song, do storytelling, and in part, it already exists in MSF. You can learn more about organizations sitting in a bar with a bunch of expatriates than in an official meeting, right? So, and then high turnover as well is an issue, and if you compare nomads culture, there is high turnover. A lot of people don't survive till old age. They don't just grow old, right? And a lot of children died before age of 5. But there is tradition that actually follows because there are some elders and there is tacit knowledge that is preserved. And maybe when you look a little bit different on your own style of learning, you will be able to adjust your own principles. As the saying goes, if you judge fish on its ability to walk, the fish would be really stupid, right? So you cannot compare and adjust different methodologies that are okay in different culture, in sedentary culture, and try to become someone else. I hope this clarifies somehow. Thank you.
I don't know if, do you have comments that you want to specifically address?
You know, very quickly, just to say that, yeah, the advocacy review was actually internally focused because that was the decision also of ExCom at the highest level that thought we had actually a lot to learn internally without making it a comparative study with other organizations, which could have been possible. But then the risk is we come back and everyone says, well, look, MSF is very different from all those others. So, you know, how useful was that? Secondly, I think, yeah, for the question of, disbelief in advocacy, maybe I put it wrong in that basically, yes, I think, as you said, like the example of the colleagues in Yemen, actually a lot of people don't realize that actually what they're doing is a form of advocacy. You know, that's sort of what I would call reactional or operational advocacy. And so that's often the sort of maybe a misunderstanding that actually staff are doing advocacy basically every day. Thanks.
Okay.
I did just make one quick comment. I think from the evaluation of the SSP, I think one of the key messages was that clearly they had witnessed against a problem, which was the failure of the current policy and system to provide adequate drugs, but they hadn't thought through clearly what they were advocating for besides policy change. So you can measure that, yes, there was policy change, there was system change, but because they hadn't set clear objectives about what kind of policy and system change they were looking for, they weren't totally happy with what the policy and system change were. And they also hadn't then thought clearly through and set objectives how these policy and systems would be implemented on the ground. So I think that was a kind of one of the crux of the evaluation, was to let the Stop Stockard program, the coalition, go back and rethink what they had done and maybe put more rigor into the objectives and therefore measuring what they wanted to achieve.
Okay, thank you very much. So what I'll try and do, we've clearly heard, as wrap up, we've clearly heard from everybody that the objectives, without clear objectives, evaluations are always going to be difficult, but we've also heard that it's not just about advocacy, and I think all the panelists made it very clear that we're talking about evaluating programs. I think Hernan was very clear also that even within his team, he tries and integrate the staff fully within operations and be part of a broader review and not just an advocacy review. So how we kind of approach this without making it mammoth is going to be difficult, but clearly part of the program. We've also heard that the further we are away from our direct program implementation, the least pertinent we may be with the advocacy that we're doing. Then in terms of documentation, as nomads, we're not very good at documenting. We like to talk a lot, but we're not putting anything anywhere on paper. But we need more evidence. We need to build up the evidence to be able to then do what, in some ways, the stockout did, which was through the evidence trigger change, but something was missed out in between. One thing that came out as well is a turnaround. You know, we do evaluations. Are we able to learn from them? It takes too long. Can we find other methodologies that is actually more monitoring, evaluating on the job directly to be able to draw the lessons? So that kind of monitoring and evaluation, the importance of it, what levels, who done by who. I think you were very clear, Monica, that, you know, for you, there's a lot of it that's in the direct operational line, and it was reinforced by what you're saying, Beatrice, in terms of that reactive advocacy, that's everyday job of our operations. So it links back as well to the support that needs, but how do you evaluate that first level of access, that second level of protocol change, and then the bigger kind of campaigns that we go for hospitals or for migration potentially. So the difficulty also of aligning a political choice of being separate entities, but, you know, Rebecca raised, well, can't we have, you know, we should be able to identify the one or two clear things that we can mobilize on, but we seem to have that problem the higher it gets and the more political it gets to actually have that kind of alignment, and much less so when it's more anchored in the direct patient care. So out of all this, I mean, what at least we've got, I think, from this workshop or this session, a definition of advocacy, whisper in the ears and piss in the boots, with a kind of I guess, strategy and objective being laid out from the beginning of the project. That might help. But I think we're more or less wrapped up here, Tim. Thank you very much.
So we take 20 minutes for coffee and a chat, and then we come back in 20 minutes.